Okay. Okay, you heard that.
Mhm.
Um, so the basic concept is that we will start with the arteries. So the heart is not just a pump. There are arteries and veins. The veins are the venous stasis or stasis. The arteries are the arteriosclerosis and atherosclerosis. Okay, so we will go over the basic concepts. The cardiovascular physiology, Monse, is a little hard. So there are a lot of terminologies that you have to memorize and to master. So you have to learn the definition. Unlike the first exam, it's just about cell death, necrosis. This one is more specific. And in every structure, there is a dysfunction. Like, for example, arteriosclerosis and atherosclerosis are disorder of what? The arteries. And then what do you call this? The varicose veins are the venous system. Okay, so this is the arteries. So first of all, you have to recall the muscular walled blood vessel. And what are the parts? The endothelium. You have to recall that basic anatomy because you have to know how the blood flows inside the blood vessel of every arteries. Now the arteries, there are major arteries and there are minor arteries until it goes into capillaries, and then there's the capillary bed, and then goes to venules, and then going to the venous system. Okay, you know that, right? So the arteries, my mnemonics here is A, away artery. That's it. I know that arteries are away. So the higher pressure, the greater the resistance, the heart must work against. So what do you understand when there is higher pressure? What do you
When
understand about?
when there's more pressure, the heart is working more, so there's hypertension.
Yes, yes. So what happens when there is high pressure? What happens? Tell me.
Um, the heart has to work more for
Yes,
like
yes.
oxygen.
And there is what you call PVR. I'll give you an idea. PVR. What is PVR?
Mm,
Peripheral vascular resistance. So you see, the greater the resistance, this is the PVR, peripheral. And what is the peripheral, Monse? These are the peripheral.
mhm.
Because what is the central? This is the central. And this is the peripheral. So, what are the parts in the peripheral? Outside the heart. The heart is the center, but the peripheral are the arteries. So, it's talking about the higher pressure of blood in the arteries. So, the greater the resistance of the blood, the more it will work. So, when the heart overwork, what happens? Hypertrophy, right? So, you have to remember this is a classic question. What do you understand about arterio? There
Um,
is? Yeah, it's
the
here.
yeah, the hardening and narrowing of the arteries.
So, how does it happen when it hardens? What is the cause? You said it earlier that they are working.
Too hard.
Yes. Because when the heart works too hard, honey, what happens? There is what? Hypertrophy, right? So there is enlargement. Remember, we started with the cell. It's the cells started to hypertrophy. Remember, so from the basic cells, and then it will go to a muscle cell, and then it will, that's the arteriosclerosis. Why do you think the arteries are narrowing? Because they are hardening due to the pressure, high blood pressure, the pressure. So this is more of vascular. Vascular meaning arteriosclerosis is more happening in the arteries. Do I have a pen last time? Did I use a pen? No, right?
Yeah,
Like I want,
you did.
I did.
Yeah.
Yeah, where can I get that? I
Well,
forgot.
you put here where there's where it says annotate.
Annotate, view options. Oh yeah, yeah. Okay, annotate. And then, oh yeah, yeah. Is this, can I use the mouse?
Yeah.
Okay, yes. Okay, good. So, oh, it is so small. Anyway, it's not working. Um, which one I will use? How do I use it? The arrow? Can I use the arrow? Oh, okay.
Yeah.
That's good enough. I don't know how to use this stuff. That's good enough. Okay. Just bear with me. So here, when you talk about arteriosclerosis, it's about arteries. But when you talk about atherosclerosis, what do you understand? There is,
There's there's plaque buildup.
yes, and what is plaque buildup? What is it? What is a plaque?
Plaque is
It is composed of
uh,
what?
isn't it like when your cholesterol, when you have high cholesterol,
Yes, and what is a cholesterol? You're there, you're almost there.
like the lipids, the fat,
Yes, very good. And one more word. The basic word for lipid. What is it? Proteins,
carbohydrates.
no, proteins, carbohydrate, and fats. When you talk about atherosclerosis, it's all about the fats. You're correct. I just want you to break it down to a simple term. So, there is what you call, can I write here, Monse? Maybe I can write, right? Yeah,
Can
yeah.
write.
Okay, I can write, right? There is what you call white. Oh, it's blue. Wow. Can I make it dark? Black. Okay. Yes. There is what you call atheromatous plaque. Okay. This is atheromatous plaque. It's another layman's term for that is it is also known as fatty streak.
I can't see. I can't see what you're typing. I don't know why.
You cannot see what I'm writing?
Mm-mm.
Oh, really? Okay. So, okay. Okay.
I'm
Then
sorry.
if you cannot see it, let me just put it in the chat. Okay, okay. Where do I write it? Okay. So there is such a thing as, what did you do? You change it?
On accident. It's because it kept doing this, and it was annoying me. Let
Really?
me put it back.
Atheromatous plaque. Remember this, Monse, so that you will, when you go to the exam, you know atheroma is different from arterio. So atherosclerosis is different. Atheromatous plaque. And this plaque is also known in layman's term as fatty streak. So, what happens? If there is too much cholesterol in the body, what happens? There is the plaque buildup, which are composed of lipids, also known as fat. That's why they're called fatty streak or atheromatous plaque. Remember that. Because
Did
Monse,
you put it? Huh?
huh? I put it in the
You put
chat.
it? Yeah, I didn't see it.
You didn't see it?
No, can you see this?
Yes, I can see that. Oh, okay. Oh,
Oh,
sorry.
now I.
I did not send it. I just typed it. I'm sorry. Anyway, behave. Next page. Behave, Marmy.
Okay.
Next page. Okay. I like this. I like the heart, but it's difficult, to be honest with you. Now,
Yeah.
can you show me a picture of the tunica intima media? Do you have an anatomy of this? No?
No, I can look it up though. Should I look
Huh?
it up? Should I look it up?
Yes, because I want you to picture it. Why? So that you will have a good picture of it when the blood is flowing. Okay. Did I send you a picture of it? I
I
sent
don't
you a lot
know.
of pictures. Look if there's a picture that I send you. Because I want you to appreciate the. Or if not, I did not send you. No, no, I don't
Oh,
have. I just send you definitions. I
well, I
don't.
see it here.
Huh?
I see it here on this picture I looked up.
Okay, good, good, good. The picture you look up, you can send it to the chat, or you can just look it up. I'll just talk about it. So look at the intima. The intima is the inner lining, right? And then the damage here may lead to arteriosclerosis and atherosclerosis. Why? The arteriosclerosis is hardening, right? Hardening.
Mm-hmm.
And the other one is fat. One is hardening due to increased pressure, and the other one is fat. That's the difference. Once you remember those two, they always ask that in questions. Okay? So the next is the media. It's a smooth muscle. Always remember, it's a smooth muscle. What kind of muscle? It's smooth. Regulate blood flow, alpha adrenergic nerve fibers. It vasoconstricts and vasodilates. So it's the media that's responsible for that. And I want you to remember calcium. According to my professor also, calcium is very important. It has an important role in cardiovascular system. So because the increase, why do you think calcium is important in the cardiovascular system? Because we are talking about what? We are talking about muscle. And what does calcium do to muscle? Remember?
Strengthens it.
Yes, the calcium is the one um, activates the actin and the myosin, right? The troponin, you remember that? So,
Yeah.
here in the tunica media, it is responsible for the vasoconstriction or vasoconstriction, whatever it is, because I have accent. And the calcium channel blocker will relax the vessels. So, if you have a certain heart condition and it's vasoconstricting, remember it's the media, there's a muscle. Always remember, where there is muscle, there is calcium. Because calcium is responsible for what? Contraction of muscle. And we are talking here about smooth muscle. Okay? So, if it vasoconstrict too much, the calcium, what's happening? The calcium is undergoing too much contraction, right? So when it's contracting too much, it needs to relax, or else the blood will not flow. And if the blood will not flow, what's going to happen? There will be ischemia, right? Are you
Uh,
following?
no, I think I'm not following. I think it was too fast.
Oh, it's too fast. I'm sorry. I'm sorry. Okay. Where do you want me to restart?
So calcium, it causes vasoconstriction.
Mm-hmm.
Vasoconstriction, that's bad. That's bad for the heart, right? Because it won't let blood flow in
Mm-hmm. Mm-hmm. Now, what is the role of calcium in the muscle first?
to like give it strength and all that stuff.
And
And
also contraction.
oh,
Contraction. Remember? You remember the actin and myosin? The sliding filament theory? Remember, the calcium should be there for the muscle to contract? Remember?
mm-hmm.
Now,
Yeah.
if the muscle contracts too much, what's going to happen? There will be vasoconstriction. So when there's vasoconstriction, do you think the blood flow will be good? No. There will be lesser blood flow. So if there's lesser blood flow and there is no relaxation of the vessel, right? So that's not good. So why do you think there are heart drugs like the calcium channel blocker? It will block the calcium. The drug will say, "Hey calcium, stop contracting. The blood needs to pass by." Huh? You have to relax so that when you relax, there will be room for the blood to pass by because we need to oxygenate some parts of the body. Yeah, I'm doing like that so that you will understand. So, are you good now?
I'm good.
Yes, yes. So with alpha and the beta, it's just the opposite. If there's too much vasodilation, you give a drug that will vasoconstrict. If there's too much
Oh,
yes, that's it. So
that's why that's why hypertension is a beta blocker, right?
yes, and what's an example of a beta blocker? Metoprolol.
Lisinopril.
Everything that yes, anything that ends in olol, olol. Okay, now the external. What's you've seen this in your anatomy, so it's just the outer covering. All right, just look at your anatomy. You have a picture, okay? Yes, this is it. Okay, you have a picture. That's good. Okay, so remember this. So that you know why you have to picture this in your mind, so that you will understand, oh, it's vasoconstricting because the smooth muscle, oh, it's the calcium responsible for it. So that's it, you have to remember that what's
Okay.
happening. Okay, you're good. Next, the endothelium function. That's why anatomy is very important in pathophysiology.
Yeah.
Now, the endothelium function, where's the endothelium? The endothelium is the inner one, right? Excuse me. So there is the fluid filtration, maintain blood vessel tone, semi-permeable barrier, neutrophil chemotaxis. Remember, we defined chemotaxis before. Anything that you defined, you have to remember them, what they mean. Because these chemotaxis is like going to the site, like, you know. So,
Yeah.
yeah, vessel dilation, nitric oxide. Um, so nitric oxide is responsible for the vessel dilation and vessel constriction, the endothelin. Angiogenesis is, what is this? VEGF? Vaso VEGF. Did your teacher says about VGEF?
Mm-mm.
V. Let's, maybe we need to Google that. VEGF. You can look it up. I'm looking at the diuresis and the C-type natriuretic peptide clot prevention. Prostacyclin is an antibiotic. It's like tetracycline, antibiotic, and clot formation, thromboxan A2. Thromboxan, anything that has something to do with thrombocytopenia, thrombus, they're all platelets. So, platelets is responsible for what? Clot formation. So, the endothelium function, huh? What?
I look at VEGF is the growth factor.
Yes. So it's so endothelium function is just telling the endothelium function. So these are the function. You know, i i I don't know if your questions will be too specific, but I don't think it will. This is for anatomy question. Your questions mostly will be on drugs and on the pathology and on the different kinds of disease. That's it. So here you have a picture. Just remember this picture. Okay. Okay, go to the one that you don't know. If you know all of these things, just skip because you have a lot.
Mhm.
And I think you're very smart, Monse. You know the stuffs you okay. This is the injury, right?
Yeah.
So when there's injury, there are only two kinds of injury. Arterio is what? Again, it is the
The artery.
what
The
happens to the artery? They letter
they
H.
yeah, they knit harder
Very
harden
good. They
the
harden. And the atherosclerosis is what?
the plaque buildup.
The plaque, the lipid, or the fat. And the endothelial injury attracts WBC. Remember, we discussed about the white blood cells, right? They are for the they come, what do you call that? They do the chemotaxis, they come to the site of injury, right?
Yeah.
That's it. So, okay, let's go to the blood flow regulation. The blood flow inversely related to the diameter of the vessel. What do you understand with that?
Mm, so the blood, what, how big is the vessel is how much blood is gonna flow through it.
This is the opposite. When you say directly proportional, let me put it in the chat room. Directly proportional. When you say directly proportional, this means that they go together. If the other one increases, the other one increases. Okay? But if you say inversely related or inversely proportional, whatever, is the same word. This is what you call the opposite. Okay. So, opposite. Remember that. I put it in the chat. So, what happens here? If the blood flow is increased, what happens to the diameter of the vessel?
It will get smaller.
Yes, the term is it will decrease. You have to understand, Monse, like physiology. Pathophysiology is the same thing. It's about the increase and decrease. If one increase, if the other one decrease. Okay? So always remember, blood flow and diameter of the vessel are inversely proportional. Why do you think is that?
Mm,
If there's an increase in blood flow, what happens?
well, then there's so much, so it gets, I don't know. So there's
Yeah,
too.
yeah, as long as you know the idea that they are, if one goes up, one goes down. All right? So, flow from the large diameter to small diameter reduces the flow and increases the pressure. Okay, so this is getting complicated now, Monse. So, there is now the pressure. Okay? So, flow from the large diameter to small diameter. So, large diameter vessel. We're talking about the diameter. Diameter, okay? The diameter. It so from the large to the small, it there's decrease flow, right? Because from the large going to the small, it gets smaller too, right? And what happens when the diameter gets smaller? What happens to the pressure? Increase, decrease?
Increase because there's too much.
Very good. Now, so there is such a thing as resistance affected by vessel diameter. So this is what I'm telling about peripheral vascular resistance. Peripheral meaning outside, vascular meaning arteries. When you talk about vascular, it's always about arteries. Although veins and nerves are also, they're the trio, but then vascular is always about arteries affected by vessel diameter, vessel length, and blood viscosity. Okay, remember those three words that
You
they.
know what? You know what blood viscosity means?
Okay, I want you to look at the definition of viscosity because I don't want to define it for you. When the blood becomes viscous, what does it look like? Hmm? Hold on, let me.
Um,
Yeah, what does a viscous blood look like? Blood viscosity. Okay, a blood. What is the meaning of blood viscosity? It can be defined as the resistance of fluids against the flow. So, includes friction between the elements. So, what do you. Okay, hold on. Which causes RBC aggregation and decrease blood flow. Okay, or by any pathological. Okay, so if it's viscous, um, I want to define the word viscous for you. What the effects of viscosity? Okay, end the end result of viscosity will be there will be decreased blood flow or any pathological elevation of the components of blood. So, what do you understand with that? The viscosity. The viscosity meaning that there will be an increased blood flow. Meaning, okay, it's hard to explain. I do understand it, but it's hard to explain. Like when there is clotting, I hold on, hold on. Okay, so that's the blood viscosity. You have to be familiar with the blood viscosity, the vessel length, the length of the vessel, like, and the vessel diameter. So if the vessel is large or there's a small vessel, that's the vessel length. The vessel diameter, is it big diameter or small diameter? And blood viscosity, are there aggregates of platelets? So if there's aggregates of platelet, then it will impede the blood flow. Something like that. So the blood flow, you have to remember this. This is a um a formula. Okay? So the blood flow is equals to BP or blood pressure over resistance. What do you understand about that? Are you there?
the blood flow depends on the blood pressure and the resistance.
Okay. What did we talk about? Think, Monse, like directly proportional and inversely proportional. So which is directly proportional? Look at my formula. Which is directly proportional to the blood flow?
Um,
The blood pressure.
yeah.
Yes. And which is below the denominator. That is the resistance. So the resistance and the blood flow are what? They are opposite, right?
Uh-huh.
It's a simple math. The one above, BP is equals to blood flow. They are directly proportional. But blood flow below below it is the resistance. They are inversely proportional. So how do you state that, Monse? If the blood flow increase, what happens to the BP?
It increases.
Yes. And if the blood flow increase, what happens to the resistance?
Decrease.
Yes, because they're opposite. Monse, you have to remember that by heart. Which one is directly proportional, which one is inversely proportional. So that when they ask you a case study, remember, Monse, it's all about the case study, what's happening to the patient. So it's not, we are no longer in anatomy and we have to define them and we memorize and we know this will apply to the disease you have, and then the disease will be in a scenario that you have a patient. All right,
Mhm.
that's it. So remember that. Hey, honey,
Yes.
this one, can you go back to that one?
Oh.
Okay, okay, just
Yes.
remember these terms. Okay, next. I thought I missed something. Okay, there's another formula. What's the next formula?
Mm,
The BP, let's go to the BP, is equals to the cardiac output times what? The peripheral venous resistance. Okay, so this is a question two in my exam. I send you all my questions. Don't worry. I send you. You have to review that. Those are cases, okay? You have to review that, Monse. And you have to review why is that the answer. And if you have questions, text me. Why is this the answer here? Because it came from my professor. So here, what is what are the two things that you have to be together with the BP
the CO.
and the PBR? Okay. Now, here, what does this mean? It's a multiplication, right?
Yeah.
It means both are directly proportional to BP. So if there is an increase in blood pressure, what happens to the cardiac output?
It decreases.
No. There's no, you see, do you think there is a numerator denominator? Nothing, right? Everything is
Mhm.
directly proportional. So if it's directly proportional, if there's an increase in BP, what happens to the cardiac output?
It increases.
Very good. And if there's an increase in BP, what happens to the peripheral vascular resistance?
It increases.
Very good.
I don't
Very
get
good.
it because if you raise the blood pressure, then doesn't that mean that there's not enough blood flow?
Now, if you raise the blood pressure, what happens to the vessel? There is what? Vasoconstriction or vasodilation?
Constriction.
Yes. So, when you increase, uh, what you're talking about is about the vessel diameter. Here, it's talking about the flow of blood. So, in blood pressure, there's always vasoconstriction. But then, what happens to the cardiac output? Okay, I'll give you an example. If the blood pressure is increased, so it's vasoconstricted, do you think the blood flow is fast or slow?
Slow.
Slow. So, if it's slow, um, um, but then it's working against the gradient, right?
Mm-hmm.
So, if it's working against the gradient, okay, let's put it this way. Why would it have an increase in cardiac output? Because the heart is pumping hard. It's pumping hard. It's giving a lot of cardiac output to enter what? That little passageway that is constricted.
Yeah, I get it.
Yes, now you understand. Now, when there is an increased blood pressure, what happens? When it's going, inserting its way to the small vessel, what do you think happens? There is also an increase in peripheral vascular resistance. Do you get it now?
I get it.
Yes, good. Okay, let's go to the next. No. There's one more. One more. These parts, these are not important. The laminar turbulent, you can do them. There's one more. Go back to that. Go back to that.
Oh, there's not.
No, the cardiac output.
Yeah, we already went over it.
Yes, but this is a different. Okay, Look, Monse, it's another formula. These are the three questions. You know, yeah, just look this up, okay? That's it. You already know. So if there's an increase in BP, increase cardiac output. But if there's an increase in cardiac output, is the peripheral vascular resistance increase or decrease?
If there's an increase in cardiac output,
What happens to the VBR?
increases.
Decrease. Why? It's in the denominator.
Mm-hmm.
It is what you call what? Inversely proportional. But what is directly proportional with the cardiac output? The BP.
Mm-hmm.
Yeah, you have to remember this. Okay, let's go. Let's go to the next one. Yeah, these are very important, Monse, because the next one, this one, you can memorize all of this. This one, Laplace Law, you can memorize this. I don't need to really explain to you the definition of these terms, like the arterial wall tension. When there is
I,
tension,
I'm
what?
I'm gonna look at which ones I need help with.
Yes, yes.
Yeah, not this.
Yeah, not that. I don't think so. Those are just definition. Monse, you can do that. You're very smart. Oh, this is important. Orthostatic hypotension. This can
Yeah,
be
this
in
one.
cases. Okay, you know this. Okay, somebody, become a DC and then they can fall. Okay, you already know this. RAAS. I think we discussed this. The renin. Did we discuss this?
Which part? The,
RAAS.
oh,
Renin-Angiotensin. You already know
I
this, right?
don't, I don't remember it though.
Oh, you don't remember? Okay, go to that slide. Put it here because we are in orthostatic hypotension.
You want to go to Ross first?
Ah, you want the orthostatic? I thought you know this already. So, in orthostatic hypotension, there is a drop in blood pressure. Okay, so a person will be lying down, and then when they stand up,
They
the
get
blood
dizzy.
pressure will go down. So they
They
get
could.
dizzy, and then they tend to fall. That's why if you're a nurse and you know that the patient has an orthostatic hypotension, you when the patient stands up, they want to go to the bathroom, you have to be there or else they're gonna fall. And sometimes as a nurse you will have four patients. Okay, so there's
Wow.
decrease in BP sensed by baroreceptors. So okay, imagine this. The person has the blood until here. When they go up, the blood goes down, so there
Mm-hmm.
is a drop in blood pressure. When the blood pressure goes down, the baroreceptors here will sense it. So there will be the activation of what?
The
SNS,
sympathetic
sympathetic
nervous.
nervous system. So the sympathetic nervous system will say, "Hey, there's a drop in BP," and it will activate an increase in heart rate as a compensatory mechanism. The body compensates. Like hypertrophy is what? It's a compensatory mechanism to the blood flow, right?
Oh,
Yes, in
so
pathology, you have to compensate.
when you're hypotensive,
Mm.
then you have tachycardia because your heart's beating. You have
Yes,
uh
the heart is working hard. Yes, yes. And when there is tachycardia, what happens? There is also an increase in heart rate.
okay.
Okay, you know that. Okay, the renin-angiotensin aldosterone system.
Oh yeah, I need to know this. This one I need to know.
Yeah, yeah. I did not discuss this with you. No?
I don't remember it. Like no, 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 no.
Oh, okay, okay. Now, the renin is a hormone. Okay? So, the hormone renin is from the JG cells of the kidney. Remember that. In response to low pressure or perfusion. Now, here's the thing. If there is hypotension, remember there are two things, hypertension, right? So, if there is a low BP, there will be a signal, help, help, we need supply of blood, there is hypotension. What will the renin do? It will go there. It will help because there is low pressure. Low pressure means low blood pressure. Okay, so the
Okay.
renin the JG apparatus will release the hormone renin. Renin is a hormone, okay? If you're asked in a question, well, I think you already know this. So then there is the inactive angiotensinogen, right? So anything that with ogen, like pepsinogen is the inactive, the active is the pepsin. Here,
Oh,
and yes, anything with ogen is inactive. Because why is it inactive? You're not using it. But if
right.
there is like low blood pressure or high blood pressure, hey, we need help. Like, for example, there's a fire. And you know, the fireman, they don't do anything in the firehouse, right? They play cards. But if the fire, hey, fireman, come here. So they will be activated, right? The same thing here. Oh,
Okay.
there's low blood pressure. Activate the angiotensinogen. It's just inactive. So the liver will release it, right? So
Right.
with the help of renin, it will convert it to angiotensin 1. Mm-hmm.
Okay.
So okay, after that, this is I want you to look at the flow of this conversion. But then I'm telling this to you because it will be a waste of time if we look at the picture. But I want you to Google images this later on. You can do that. So
Mhm.
once it converted to angiotensin 1, it needs another conversion to angiotensin 2. And it is converted by ACE, angiotensin converting enzymes. Okay? So, there are two hormones here. What are the two enzymes? Sorry. Renin is a hormone, but it's also an enzyme. It's acting as an enzyme. So, here, the angiotensin converting enzyme. So, you've heard about ACE inhibitor. You remember that? They're drugs, right?
Yeah,
Yes. So
kind of.
this is the ACE inhibitors, honey. This is the function of the drug. Like if you have a patient with a heart failure who's taking ACE inhibitor, this is the rationale with it. That yes,
So the ACE inhibitor is taken when you have low blood pressure, right?
um the ACE inhibitor. Oh, you are yes. To increase, very good, very good. To
Right.
increase the blood pressure because you have low blood pressure. But
Hmm.
if a patient have hypertension, do you need this?
No, you
No.
need beta.
No, that's why you have beta blocker, calcium blocker. Yes. Okay. So the angiotensin 2, always remember, it is a vasoconstrictor. And when the vessel vasoconstrict, Monse, what happens? There is
It gets smaller.
yes, and there is increase in peripheral vascular resistance. So, angiotensin 2 is it activates the aldosterone for the adrenal cortex. So that's why this is the renin-angiotensin aldosterone system. So the aldosterone stimulates the sodium and water retention by the kidneys to increase blood volume and pressure. Why do you think that the aldosterone needs to stimulate the sodium and water? Why? It's there. Just answer me. Two?
Because it's retained by the kidneys,
No,
and
no.
so
Yes, the next one. To
to
increase?
increase pressure, blood
Yes,
volume.
yes. So, this is for low BP. But for high BP, what do they give? Diuretics, right? Why? You need to excrete diuresis. You need to excrete in the urine the sodium and water because the sodium in water is responsible for what? The high BP. So what do you give to the patient? You don't give ACE inhibitor. You give diuretics. You have to remember this, Monse. These are very important. You will have pharmacology. All right? So
Diuretic
this,
because they have too much sodium and water.
yes. So if you have too much sodium in water, it helps the hypotension. It helps the low BP. But too much sodium in water, it's bad for the high BP. So you give the person with hypertension what? Diuretics. So
Okay,
that
so
they will throw it out in the urine so that the sodium will get out of the body because the sodium has too much body. What do you think happened, Monse, if you see a patient with swollen feet? They have too much sodium, Monse. So if
Right.
they have
Okay.
swollen feet, you have to give them diuretics so that they will excrete it in the urine, so the swollen feet will be gone.
Okay,
All
so
right?
if a patient has, if they have low blood pressure, then we need to have more sodium and more water for to increase the blood pressure.
Mm-hmm.
And if we have high blood pressure, we need to give them diuretics so they can excrete the water and the sodium to lower it.
Very
Okay.
good. So, uh, combination of vasoconstriction and okay, now we are going to the antidiuretic hormone. What do you understand about antidiuretic hormone?
Oh, that's so they don't pee, so they don't excrete
Yes,
to
and what do
to
they retain?
the water and sodium.
Yes, yes, very good. Now you know this. You already know this. So let's go to the next. That's the simple explanation that they prevent you from excreting it. They prevent you from urinating it. Okay?
Mhm.
Natriuresis. So this is a ANP, atrial natriuretic peptide. Did we discuss this? I think we discussed this. Do you remember this?
Let
ANP?
me let me see if I need to know about it.
Mm-hmm.
Because if not, we can skip it. Because I have my own PowerPoint here
Yes, yes. Mm-hmm.
that shows what's gonna be on the test, but
Oh,
I feel
this
like
is not your PowerPoint.
this is my PowerPoint, but this is more extensive. That is because I don't know. It just helps me realize because this is showing what's gonna be on the test, but the description is very small.
Ah, I
I mean,
understand.
we can go over this one if you want, but I don't
No, no,
know.
no, no, no,
It's
no. You're the student. It's up to you. It's not up to me. Because you know what? Whether we make it smaller or bigger, you know, it doesn't matter.
okay. Well, I don't need to know about this.
Hmm. So what's next? So this one, this is coming from the brain, okay? Brain natriuretic peptide. All right.
I need to know here something about this.
Ah, hold on. What's happening here? I'm trying to minimize zoom. Okay, I have it. It says I have. Okay, now I maximize the zoom. Okay. Yeah, yeah. Which one? The free radicals. Oh, Monse, you can do this. The free radicals, the nicotine. Oh, this is the what do you call this? This is the treatment management, right?
Yeah. You know what? Actually, this is too much. I'm gonna switch it. The other one is less, and can I switch it?
Yes, yes. By all means, I'll just pause the recording. Okay, let's start. The acute coronary syndrome. There are two types. Okay, the unstable angina and the MI. Now, in the group chat, I sent you the definition of unstable angina. There is the stable angina and there is the unstable angina. The stable angina is still good, but then this one is the classification of the pathologic ones of acute coronary syndrome. So, when you say acute coronary syndrome, what is affected? The coronary artery. It's giving you away the tip. Okay, so you have to look at the coronary artery. So the coronary artery is a big vessel, right? So unstable, meaning when you say unstable, there is irregular, right? So and the myocardial infarction. What do you know about infarct? An infarct is ischemia, right? Infarct is cell death. So myocardial, myo is the heart muscle. So this means that there is no blood supply in the heart muscle, myocardial infarction. And this is the stroke, the MI. This is the stroke. All right? Do you have a
Okay.
question?
So yeah, what's the difference between stable and unstable? I know that angina is chest pain, but what's
Mm-hmm.
the difference?
Well, the stable has a regular, it has a regular rhythm, but the unstable angina has an irregular. I told you unstable. When something is unstable, there is irregularity, right? So there is
But
irregular in rhythm, irregular in
that
blood
means
flow, everything irregular.
is there worse than stable?
Oh yes, that's why it is an acute coronary syndrome. And what do you understand about acute? It is sudden onset, right? Acute.
Right.
Yeah. So that's it. So angina, oh here it is. So it's consistent. When you say consistent, it means the same wave, consistent. Same height, same wave, consistent. Start
Okay.
medication with nitroglycerin. Nitroglycerin is a sublingual drug, cardiac drugs, okay? The unstable is no episode or increased severity. So when you say increased severity, first it will start ting, ting, and then going up, the severity is increasing. So if there is increased severity, what can you infer, Monse? It means it is irregular, right? Do you agree?
Mhm.
Yes. And then new regions of heart experiencing ischemia, meaning there is little ischemia in this part of the heart and increasing severity, there is worse ischemia in the next part of the heart. So there's a little ischemia here and there's a big ischemia here. And what is ischemia? Lack of blood
So
supply. Yeah. That's why it's a medical emergency because you don't know which part of the heart will have big ischemia and small ischemia.
got it, got it,
Yes,
got it.
yes, yes. That's why they are unstable, they are irregular. There is severity, there is difference in intensity. The MI known as a stroke. So this is prolonged ischemia. Now, there is also MI in acute stage. Did you see acute coronary? What is acute again? Sudden onset. What is chronic? Prolonged. Chronic prolonged. Okay? So there is prolonged what? Lack of blood
Blood.
supply, prolonged ischemia. So that's why it's now categorized as an MI. And it leads to what? Irreversible damage. When you say irreversible damage, it means what's happening to the heart muscle. It will be damaged for good, right?
Right.
So when the heart muscle is damaged for good, then there is already a pathology in the heart of the person. And why do you say there are reversible damage? There are reversible damage like a person will only have tiny stroke. Another word for tiny stroke is TIA, transient ischemic attack. It's a little stroke, mini stroke. Like I'm talking to you, Monse, and I'm having mini stroke, but you don't see it. But then my heart is having mini stroke, mini ischemia. So after a while, it's gone. It's still reversible. Reversible meaning it's going back to normal, right? And irreversible meaning it's not going back to normal. It's damage for good. You understand, right? So there is blood flow obstruction, myocardial oxygen demand exceeds supply because too much demand, and delayed request for medical help plays a role. That's it, because they are disregarding the acute episodes.
Got
So yes, that's it. Okay, next. So ischemic cardiomyopathy. So this is related to the heart muscle, okay? So ischemic, lack of blood supply, cardiomyopathy. The muscle, the heart muscle. So the heart tissue is compromised. Heart tissue, heart muscle, what composes the um it's cells, tissue, and organ, right? So heart tissue is just a little part of the organ, of the heart organ. So the heart tissue is compromised. So it means part of the heart is compromised, unable to generate adequate pressure. All right? It cannot generate adequate pressure. Why? Because the heart tissue is not fully functioning in its contraction. What did I tell you? It has something to do with calcium. Contraction has something to do with calcium all the time. So if there is compromised heart tissue, then there will be no adequate pressure. Because, honey, let's put it this way, the heart has to pump a certain amount of blood.
Mm-hmm.
If the amount of blood is lesser, there will be problems in pressure, cardiac output, so what happens if the pressure is not adequate and there's cardiomyopathy? What happens? There is fibrosis. So what do you understand about fibrosis?
Uh,
From the word fiber, what happens to the heart muscle fiber?
they die.
Yeah, they die. But fibrosis meaning that there is more fiber formation. So when there is fibrosis, what happens to the fiber formation? There will be hardening, right? And once it hardens, there will be scarring of the heart. So do you think a heart with a scar tissue, like necrosis, do you think it will function well? No, no.
No,
So
no,
that's
no.
ischemic cardiomyopathy. The keyword here is fibrosis, okay?
Okay, so if the heart tissue is damaged, there's no there's not enough pressure, so the heart is not beating enough, right?
And there is fibrosis.
And fibrosis. So
Mhm.
the fibers, they
After the fibrosis, there will be scarring.
the fiber
Okay, okay.
is
You have a
hardened and
wound,
then
right? Once you have a wound, there will be more there sometimes there are wounds that have keloid. And what is the keloid? There is extra skin, right? So here, when the heart muscle has more fiber, it becomes more fibrous tissue. So what happens if there's a lot of fibrous tissue? There will be scarring, right? That's it.
Mhm.
Glucose in arteries. Okay, so what's the role of glucose? So the glucose is bad for the endothelial cells. This is in terms of diabetics. That's why, honey, diabetic patients and then they have a heart condition, bad, bad combination. Inflammation and plaque formation may result and leads to vasoconstriction. So the glucose will leads to vasoconstriction, and the reason for diabetes mellitus being risk for coronary artery disease. I have to watch out for my glucose. Oh God, because I cannot have an increased glucose because it will give me diabetes mellitus, and an I am have an increased risk factor for coronary heart disease. Now, I have hypertension, Monse. So the hypertension along with diabetes is also bad because the hypertension is also a risk for a heart disease. Hypertension has something to do with blood flow, okay? So do you understand that glucose is bad for the arteries?
Yeah, because glucose is like plaque.
Yes, yes, yes.
Got it, got it.
hmm Aneurysm, a weakening of arterial wall causing bulging or dilation. So, have you seen a cerebral aneurysm?
Never.
Yes. I mean, put in your side note, Google cerebral aneurysm images. We don't have time to do that. I want you to look at to them because you know what, Monse, why I'm asking you to look at pictures? They are
Hmm.
visual, photographic memory. If you see them, you know them, right?
Yeah.
That's it. Google that. I want you to Google what an aneurysm looks like. An aneurysm can be berry, like this, berry aneurysm. So it is shaped like a berry, like like a berry aneurysm. Why do you think there's aneurysm? The blood is pooling there. There's a blood pool. So it creates a balloon. Okay? Like the berry, strawberry, something like that. So weakening of arterial wall causing bulging or dilation. So it's bulges. Okay? Location, cerebral arteries. So I want you to Google cerebral aneurysm.
I
So
don't understand it. So so the bulging of what? The blood?
yes, okay. I'll give you an example. You have a have you seen this balloon before you even put air on them?
Mm-hmm.
Yes, okay. So it's shaped like this, right? Just like this, right?
Yes.
Okay, okay, Monse, let's do it this way. Have you seen a condom? Right?
Yes.
Okay. So the condom, it can be like this. When you put water to the condom, isn't it that it bulge?
Mm-hmm.
It dilates? That's an aneurysm.
But with the blood or what?
Yes, because the blood stops flowing. The blood stays in one place. So what
In
will happen to the vessel? The arteries will bulge into a balloon
in the heart?
in the cerebral, in the brain. This is the brain aneurysm. This is brain cerebral arteries, brain aneurysm.
Okay. Okay.
Yes. But then take note, Monse. Why is it in the brain? Because what is in the brain? There are also arteries in the brain. Remember, you studied that. So
Yeah,
if the,
but why does that happen? Why does the blood clot and then bulge?
because there is something wrong with the blood supply in the brain. So the heart, so the if there is an artery aneurysm or cerebral aneurysm in the brain, there will be remember honey, the circulation is the brain, the heart, and to the peripheral vessels, the peripheral, the hands, the feet, right? So we have to deliver blood to all parts of the body, right? Why? To oxygenate the whole body, right? Now in cases of aneurysm, do you think there will be proper oxygenation if there is an impediment in blood flow because there's dilation, there is obstacle? No, right? So once you decrease the oxygen, because take note, the RBC gives oxygen, right? Once there is decrease in oxygen, what happens? There will be cerebral aneurysm, so there will be a cerebral stroke.
Okay.
Yes, so the stroke is not just in the heart, it's also in the brain. Okay? And this one also in the aorta, abdominal aortic aneurysm. Because if there is an aneurysm in the aorta on the abdomen, remember, there's the great aorta on the heart, but there's also an abdominal aorta. So in abdominal aorta will also have aneurysm. Okay?
Okay.
Yes. Next. So aortic, abdominal aortic, you already know this. Okay, next.
Oh, you know what this means? Brew it.
Yeah, bruit is like a murmur. You know when you put your stethoscope, remember you have a stethoscope, and then I don't know if you already had a class on if you already had a class on what do you call this? If you already had a class on heart sound. So if you put your stethoscope here in your carotid artery, you will hear if there is irregular heart rhythm, abnormal heart sound, there will be bruit, and that's a murmur. Bruit and murmur are the same. You can Google the meaning. But bruit is what you hear when you put your stethoscope here, that there is an impediment or there is a problem with blood flow. But then bruit, this is abdominal aortic aneurysm. Where will you put your stethoscope? In the abdomen, Monse, in the abdomen. Okay?
Okay.
You can remember that the abdomen is a hollow place where you can hear sounds. There is the abdominal sound, like the normoactive bowel sound. Bowel means the gut or the abdomen. Hyperactive bowel sound and the a hypoactive bowel sound. So the stethoscope, if it's abdominal aortic, you put it on the abdomen. Okay? Monse, I want you to Google the aneurysm. But then I think I send you a my PowerPoint slide. I think there's a picture there of aneurysm. Look at my PowerPoint slide. I send it to you. All right?
Okay. Did you already go over this in your class?
Yes, I already took the exam. That's why I can teach this to you.
Oh, you got a good grade, huh?
No, because it's the exam is pulmonary and heart. I studied the heart, but then my grade went down because I did not study much on the pulmonary. I wasn't able to budget the time. You understand?
Yeah.
So I only got an 86.
That's good.
No, it's
What?
not. It's not, Monse. I got a 91 in the first one, right?
86 is good.
Yeah, because there are two systems, Monse. Pulmonary and cardiovascular. So I focus more on the cardiovascular because this is difficult. The thing is, on the questions with pulmonary, I cannot answer much. So it pulled my grade down.
Mommy, what's your grade?
86
No, in the class.
in the class. I don't know, 91 plus 86. That's it. We only
See?
have two exam.
You have an A in the class. Probably.
A minus.
See, that's fine. That's
Yeah,
why
but it's not a line of 9. I wanted line of 9.
I,
I'm a, Monse, I'm a tutor. I should know these things.
I know. Did you already go to the hospital?
Hospital? Oh, no. No, not yet. Not yet. Actually, we don't have a hospital. We have nursing home.
Did you already go to the nursing home?
Not yet, not yet. Okay. Okay, here, let's talk about the aortic dissection. Tear in lining between tunica intima and tunica media. You know what's in the media? That is the muscle, right? The intima is the endothelium, right? Leading to a splitting of layers, blood flows between layers, okay? Potentially lethal. It means it's, symptom onset, okay, you have to remember, it's sudden. When it's sudden, what does it mean? Acute, right? Sudden onset, acute. It's not chronic. So chronic means prolonged, right? Know these differences. Patient hears ripping or tearing sound. Signs and symptoms. Difference in right and left arm blood pressure. All right? So there is a difference because sometimes you take the blood pressure on the brachial here and the other brachial, they are different. But technically they should be the same. Okay? So once there is a difference, then you suspect aortic dissection. And then you can see the lips is pallor or pale. Well, my lips is really like this. It's dark. But then if it's like pale or like cyanotic, something like that, you can see. And then high heart rate. So if there is a very high heart rate, and you can see the high heart rate, you have instruments now, they take the BP, the heart rate, you just see it on the screen. You don't need to worry about it. So what is just important here in aortic dissection, there is the splitting layers of the intima and media,
That's
and
bad.
the onset is sudden. It means it
That's
is
bad, huh?
acute. Yeah. Ripping or tearing sound. Next. Oh, you already know this. Smoking, you already know this. Infective endocarditis, go there.
Brute. Oh yeah, the murmur, right?
Whatever.
A brute when listening to the carotid.
Yes. When you hear the word turbulent, like there's turbulent, do you think there is a smooth blood flow? No.
No, it's going everywhere.
Yes, so it's a bruit or a murmur.
Oh, okay.
Mm.
Smoking,
Oh,
hypertension.
let me give you a YouTube. Yeah, I'll give you a YouTube of this so that you can appreciate the brewy. Yeah, we had this in health assessment. Now, in infective endocarditis, all right?
Mm-hmm.
Okay. When you say infective, what do you understand? It's infectious disease, right? So if
Yes.
it's infectious disease, the organisms are there, right? So they are the staph aureus. That's the culprit, the staph aureus. So it damages the bulbs. So the bulbs is where usually there are in the endothelium. The little bulbs. There are little bulbs in the vascular arteries. So it damages the valves. The risk factor is prosthetic valves, pacemaker, intravascular devices, something like that. So if
Oh, I get it. I get
yes,
it.
good. So we can
Mhm.
move, right?
It's like, yeah.
Yeah. It's just easy, Monse. It's just infectious disease.
Can you explain this really quick? Vegetation.
Vegetation fragments can break off and enter the bloodstream. When you talk about vegetation, what do you understand? It means there is no movement.
Mm-hmm.
Yeah. So there is vegetation fragments that can break off and enter the bloodstream. So vegetation means that it stays in one place. If the blood pools and it stays in one place, there's vegetation. So if the blood stays in one place, what happened? Oh, they clump together, right? What happened? It become an emboli, right?
Is that so? That's when there's okay, okay, okay.
Yeah, yeah, yeah. Something like that. Like and I want you to Google, because you know what, Monse, we don't really have much time to Google them because you have a lot. So these are the words that you have to look up. Remember, Monse, you have to have a dictionary. It's a must. Did I tell you you have to have a dictionary?
Yeah.
Yeah, you have to have a dictionary. These things. Okay, pericarditis. When something is ends in itis, itis. What's that? It is what? An
Inflammation.
inflammation, right? So, where is it happening? In the pericardium. And where is the pericardium, Monse? It is the covering of the
Heart.
heart. Very good. You have to look in the anatomy of that. Review, okay? Because
I
when
get that.
you see it, you have a picture. If you have a picture of the pericardium, so there is inflammation of the pericardium. So the inflammation happens between the peri and the epi. Between them, okay? There's inflame. There's the
Between the
yeah, there's inflammation and review, Monse, quick review. What are the five hallmarks of inflammation?
oh,
Hmm.
pallor, color,
Yes.
and all that
Redness. Yes.
burn
Pain.
more.
Pain, redness, heat, swelling. Yeah. Always remember that when you see inflammation, what are the hallmarks? So, if what are the hallmarks? So, what's happening with the pericardium? Maybe it's red, or maybe they're swollen. You know, these things. Now, now, if there is swelling, so what happens to the fluid? What swells, Monse? Usually it's fluid, right? There will be what? Pericardial effusion.
That's because fluid is accumulating in the heart.
Yes. And when fluid accumulates, there will be swelling, right? What swells? Anything that swells. You have wound swelling, right? So if there is something that is swelling, there is problem with what? There is problem with pressure, and there is problem with the liquid swelling. So pericardial effusion. And then the next is cardiac tamponade. Fluid again, but the fluid is accumulating and compresses the heart. Okay, which one do you think is more grave? Like which one is lesser of a lesser evil? Effusion or tamponade?
Effusion is lesser evil.
Yes, very good. Good answer. Now, let's go to the acute pericarditis. What does acute mean? A sudden onset, right? It presents in manner similar to a myocardial infarction. So, the symptoms, the clinical presentation, when you say present, it means the symptoms are the same as the myocardial infarction. That's why, Monse, you have to know what's the difference, okay? That's why you have to be good with the stethoscope. You have to listen to the heart. If you
I
hear, if you put your stethoscope to the chest and you hear, you know, a different kind of flow, and if the flow is liquid, so there must be something wrong, you know. That's why you have to be familiar with the heart sound. I will give you a YouTube of this, okay?
think
Acute pericarditis, viral and bacterial infection may occur post MI. Post MI meaning that after a myocardial infarction, there will be a complication of pericarditis that can follow. Next, symptoms: muffled heart sound, dyspnea, pericardial friction rub. Oh, okay. This one, you have to listen to the pericardial friction rub. Don't worry, Monse. I'm going to, I'll let me screenshot this so that I will remember to give you, and you can appreciate it, Monse, once you listen to them, because
I,
this you have to listen to your stethoscope. Okay.
I forgot was this dyspnea. What can you remind me?
Dyspnea is simply SOB, shortness of breathing.
Oh,
Yeah, dyspnea, shortness of breathing.
okay,
Dyspnea can happen also both in the lungs and in the heart. All right?
okay.
Okay. Next. I think you already know all of this. These are easy. These are just memorization. The Framingham criteria, it's just a
Uh,
criteria. And
this
then
one.
the cardiac output. Oh, okay, the Dressler syndrome.
Mhm.
So it is a form of pericarditis after MI. So it's not really pericarditis, but then after a person have a myocardial infarction, also known as stroke, this will appear. So this has something to do with the immune response. So first, the person needs the what's the prerequisite? The person needs to have an MI, and there should be inflammation and fluid accumulation, and the sac occurs. How will you know if there's fluid accumulation? You hear it with the stethoscope. Okay, so how do you know that there's an MI? They have symptoms of angina, you know, chest pain. So, oh, the person is having an MI. So, if you look at their chart, it's an MI. And then after the MI, you listen to the heart, and then, oh, I hear fluid. So, you can suspect Dressler syndrome because Monse, these things you can memorize them, but you have to know how to detect them in the patient. And then after you detect them in the patient, you listen with your stethoscope, you talk to the doctor. Hey, I suspect it's a Dressler syndrome. And the doctor will confirm. The doctor will put, oh, you're right. Because the nurse will also try to give their opinion. Remember that, Monse. But then, who gives the medication? It's the doctor. Who gives the order? Ah, this should go for a CT scan. It's the doctor. What does the nurse do? They document. They report to the doctor. And then they check the medication. That's why you have to be good with pharmacology. And then you will look, oh, the patient have um, 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 heart failure. So the patient was given ACE inhibitor and this amount of dosage. So, and then if the dosage is too high, you have to call the doctor. Oh, the patient has this and then the dosage is too high. Did you give that? And then maybe the doctor made a mistake. Oh my God, I made a mistake. That's the nurse. The nurse are the double checkers of the doctor. Remember that. All right. Next. Oh, it's this is easy, honey. You will just have to look at the criteria. You know what cardiomegaly, crackles is the lung sound, right? Yeah, the abnormal lung sound. Increase CBP is central venous pressure greater than 16 centimeter water. Positive hepatojugular reflux. If you put your stethoscope into the hepatojugular, on the hepato is liver. You put your stethoscope also on the abdomen to hear the you know the sound, abdominal sounds. If you can see abdominal aortic aneurysm, you also put the stethoscope. You put the stethoscope everywhere, Monse, to the chest for the heart and to the back for the lungs. Okay, so you have to check all these things. So if you have a patient, you can see the jugular vein is extended. So and then they have cough. So that's it. You just have to look at the symptoms. All right. Remember, remember this. CO is equals to HR times SB. Remember that.
What is
Remember
what is the LV right here?
left ventricle.
Oh.
Okay. Why do you think there is left ventricle hypertrophy?
Uh,
Usually, there's ventricular hypertrophy if the heart has what do you call this? Either there's stenosis or regurgitation. So stenosis is narrow pathway and regurgitation is not closing properly. So remember, honey, the left ventricle is a little larger than the right ventricle. Why? Because the left ventricle will be the one to throw the oxygenated blood to the whole body. Now, the left ventricle have needs to have a adequate an adequate amount of blood. If there is backflow, like for example, the left ventricle is in the left side, what valve is between that? Mitral valve, is it mitral valve?
I think so.
Yes. So from the left atrium, the blood should go down to the left ventricle, right?
Mm-hmm.
Now, if the blood from the left atrium doesn't all pour down to the left ventricle, and there are some blood leaking back to the left atrium. That is a regurgitation, backflow. Okay? So if there is a backflow, what happens to the cardiac output? There is decreased cardiac output, right? So if there's decreased cardiac output, decreased heart rate, decreased stroke volume. Okay? Why stroke volume? There is lesser volume because not all the blood went to the left ventricle. Remember, honey, there is a certain liter of blood that should go down. Okay, we're talking about supply and demand, economics. Okay, the liver will say, hey, heart, give me, left ventricle, give me blood. And then the abdomen, hey, give me blood. If the blood supply is not enough, so they will have lesser blood. Do you think the body will function? No, right?
No.
Yes, that's what you're saying. So you have to memorize this, Monse. CO times PVR is equals to BP, and cardiac output over BP is equals to PVR. All right? Remember this. So you memorize first the PVR is equals to cardiac output over blood pressure. Take note that blood pressure is inversely proportional to peripheral vascular resistance. That's why you have to memorize these Monse, so that you can remember them. You have to know the relationship between cardiac output, peripheral vascular, and blood pressure. They're very important. They are the key roles in the circulation. Okay? Memorize that, Monse. If you can put that in the index card, put that in your cell phone, look at it every day when you wake up. Because when you take the exam, oh, what happens? If the BP is low, what happens to the peripheral vascular resistance? Oh, it's increased. Because why? They're opposite. If one is increased, the other one is decreased. Oh, what happened? If the cardiac output is increased, what happened to the peripheral? Both are increased because they are directly proportional. Are we good?
I think we're good. Yeah.
Yeah, yeah, you will. You know why? You just have to write this. You
Okay.
write this. It's a formula. And this is the standard formula on how the blood flow will come. Okay? Write that.
One thing though, with this one right here,
Mm.
the times, the CO and the PVR, these are directly related, right?
Mm-hmm, mm-hmm.
To
If
the
there
patient.
is an increase in BP, there's an increase in PBR, there's an increase in cardiac output. But you know why it becomes inversely proportional? There is the slash, or the, you divide it. If there is, the slash is like a division, right? The one on the denominator is the inversely proportional. Whatever is in the denominator is the inversely proportional. Got it?
Got it. Got it.
Yes, yes, you're good in math. Come on, Monse, you're good in math. I admire
No,
you.
I'm
You're-
not. I'm not good.
No, no, no. It's just a simple division. So the numerator, they are directly proportional. The denominator, inversely proportional.
Okay.
Yeah. Next, the heart failure. Now, during heart failure, the heart's contractility and stroke volume decreases. So, what do you mean by contractility? These are one of the heart function.
The heart stops pumping.
Yes. So, this is what happens during heart failure. There is problems with contractility. Why do
And
you
what?
think there's problem with contraction? There is also a problem with calcium, right? Because calcium is responsible for what? Contraction.
What about stroke volume? What does that mean?
So the stroke volume, go back to your formula. What is the one related to stroke volume?
Um.
Stroke volume, the heart rate, and the cardiac output. So, if there is an increase in stroke volume, there is increased cardiac output. Yes, increased cardiac output, you throw more blood. So what will happen? There will be more volume, right? Stroke volume from the word volume. You have more volume or more liters, whatever amount. It means stroke volume. That's the volume. Whether you have more volume or less volume.
So less blood. Less blood.
Yeah,
Less
if
blood.
it's less blood, then there's decreased stroke volume. All right?
Yeah, I got that.
Yes, Monse, of course there will be decreased stroke volume because there is less contraction. So everything is less. So Monse, I want you to write a little index card. Put the arrow like this, like the arrow, like this is decrease and that is increase, so that you look at that, oh, the stroke volume is increased, because you will be asked with that question. Now the afterload and the preload. Now the preload is the amount of heart that is filled per beat, the end diastolic volume. So here, honey, you just have to know the 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 blood flow before they go for to start the contraction. Okay, what is the SA? What is SA?
The it's a node.
Yes, sinoatrial node. What does the SA do?
Mm, it,
They are the pacemaker. The sinoatrial node, they starts the, what do they start? The depolarization, the action potential. They will start to do the pump. So it starts from the SA node. So once there is depolarization in the SA node, then that is the start of the preload, the amount of heart that is filled per beat. And when you say per beat, what is that? Lub. And then the next beat, dub. Lub, dub. So the heart should be filled per beat. Now, this one is talking about end diastolic volume, EDV. So it means after the diastole. So what is after the diastole? The dub. Lub, dub. Lub, dub. The lub is S, I think it is S2, hard sound. So lub, dub. So this is happening in the dub, the end diastolic volume. Increase end diastolic volume leads to increased stroke volume to a point. So this is directly proportional. All right. Now the afterload is resistance that the ventricle must pump against. Increase afterload reduces cardiac output. So this is inversely proportional. So the afterload is the resistance. When you hear the word resistance, Monse, always remember that it's going against the flow. Like, you think you can flow here, blood? No, I'll block you. Something like that. So there is resistance to the flow. So if there is resistance to the flow, of course, honey, what does it mean? There is decreased cardiac output, reduced cardiac output, right?
yeah.
Yes, and look at the ventricle. The ventricle must pump against. What happens to the ventricle when it pumps against? It means it is working hard, right? Like you are working hard double. You have to double your work to achieve that cardiac output. And that's why it's bad. It's pathologic because you just have to work just the right amount, normal. But if you work double, then what will happen? It will lead to cardiac hypertrophy because once you work so hard, like people in the gym, if they work out so much, what happens? Their muscles grow, right? The same thing with the heart because the heart is a heart muscle. So if the left ventricle, it's already large, if the left ventricle work double, the more it will be enlarged.
Mhm.
So once it enlarges, it cannot. You know what happened to fat people? It's so difficult, right? Because they will have more fat and or they will have more muscle. So do you think it is adequate for the blood flow to fill it in? No.
Okay, I understand it. The only thing is that I don't know. I don't understand how. Like, does this happen first, or what happens first?
Okay. So okay, don't look at the pre and after. Look at where it is happening. It is happening in the end diastolic volume. Did I give you? Hold on. Let me pause. Okay, recording in progress. So now you understand that the blood flows from the atrium to atrium and then go down to the ventricle to ventricle. So it's not talking about which ventricle, it's talking about the volume of blood. So that's it. So and plus you can read more in that. Pulmonary hypertension and Frank Starling law. Okay. So the relationship between cardiac contractility, preload, afterload, SB, and cardiac output. So you have to look at these because You know, 17-3 of the book. Do you have that picture? You have to know the relationship of the contraction, the preload, afterload, and stroke volume. I don't know if I gave you a picture because I gave you lots of picture. So that's the Frank Starling law. And by the way, did I give you a book on pathophysiology? What do you call this? Pathophysiology atlas. You have that, right?
Yeah, I do have it.
Yes. Look at the picture of the Frank Starling law.
This
I think
this is this your test?
yes, that's my test. I
Oh.
memorized that. Yeah, but
How?
you know what? Only 15. How many questions was asked? 15 questions was only asked, or 10 question. So it means I have to read also, Monse. That's why the professor will not give you everything. He will give you some notes, some will come out, but you have to know all the slides. And that's
Yeah.
really, yeah, you have to know it. Okay, let's go to the pulmonary hypertension. So the pulmonary hypertension, the lungs is involved here. So there is congestion. When there is vascular congestion, what do you understand?
Um.
The
Some.
vascular is an artery, right? When you talk about vascular, remember it's an artery.
Mhm.
So there is congestion in the pulmonary field, the artery. What are the arteries of the lungs? And then pressure in the blood vessels leading from the heart to the lungs is too high. So the pressure is too high. Why? There must be vasoconstriction or increased peripheral vascular resistance. So you have to always remember, Monse, oh, this is pulmonary hypertension. What's happening to the cardiac output? What's happening to the peripheral vascular resistance? What's happening to the stroke volume? You have to know that. That's why I'm asking you to memorize that. Because for every diseases, you have to infer what's happening to those three things. Okay? So here, there is an increase in peripheral vascular resistance because there is a high blood vessels, there is a high pressure in the blood. So during
And,
high blood pressure, there is increased peripheral vascular resistance
and how does that affect the lungs?
because the lungs is giving the heart the oxygen.
Oxygen.
Yes, remember when the pulmonary artery goes down to the right atrium, is it oxygenated or not?
To the right. No.
No. So, what happened after it goes out to the right ventricle? It goes where? To the lungs, right?
Uh
The
huh.
lungs will
Yeah.
oxygenate the blood. And then what happens? The the lungs will give back the blood to the left atrium, which is already oxygenated. And then it goes down to the left ventricle, which is already oxygenated. And then it goes to the systemic circulation to oxygenate all parts of the body. Do you picture it?
I do. So
Yeah.
if there's pulmonary hypertension, there's too much pressure from the heart to the lungs.
Mm-hmm.
So so does that mean that the blood can't get to the lungs, the blood flow?
There is yes, there is high pressure going to the lungs. So if there is too high pressure, so it means there is um vasoconstriction, and if there's vasoconstriction, it will also be congested. Congestion, what do you understand about the congestion? It's congested, right? Like mucus congestion, right? Meaning there's blockage. You have mucosal congestion. That's it. And then there's the high afterload in the right ventricle. Why do you think the high afterload is in the right ventricle?
Because
Because the right
it's
ventricle will put the oxygenated blood to the lungs. So
because it's coming from the right ventricle. That's why.
so the high afterload will make it work harder to throw the deoxygenated blood to the lungs. So it's the right ventricle who bring the oxygenated blood to the lungs. That's why the afterload is high, meaning it has to pump more. It has to pump more.
Because of the blockage.
Mm-hmm. And there is high pressure because there is vasoconstriction of the blood
And
vessel.
if there's a blockage, then it's slow blood flow to the lungs, right?
Mhm,
Slow.
mhm. Why do you think it's called pulmonary? Because the blood is about to go to the lungs. That's why it's called pulmonary.
Got it. Got it.
Mhm, mhm, mhm. Remember, the blood from the heart goes to the lungs to get oxygen and then come back to the heart, right? And then
Right.
it throws all the oxygenated blood to the circulation. It's okay. What are the two types of circulation? Just a little review. Tell me.
Um, the what do you mean?
The systemic circulation and the pulmonic circulation.
Uh-huh.
So that pulmonary hypertension has something to do with the pulmonic circulation. And the systemic circulation is the circulation where it's oxygenated. You throw the blood to the different parts of the body to oxygenate the whole body. So it's systemic. Systemic meaning it's going to the different body systems. It's going,
Like brain.
yes, it's going to the liver, oxygenate the liver, going to the stomach, GI, something like that. Okay, high output versus low output. Mm-hmm. So,
What is HF? Heart failure.
yeah, yeah, heart failure. So heart failure is there's a lot of ischemia that happened already. So high output failure and the low output failure. So usually the high output failure is the sorry, is mostly on the vessel, vascular vessel. So high output failure, the heart can weaken and the ventricle can fail. So thyrotoxicosis, severe anemia. The high output failure is more severe than the low output failure. The low output failure is only on the veins, on the venous return. So example, severe leg trauma and preventing blood return. So it's a low output heart failure. But the high output failure is large blood vessels that involves toxicity like thyrotoxicosis. Thyro, the thyroid, right? So there is toxicity in the thyroid. Why do you think the thyroid is involved? The thyroid is what's the responsibility of the thyroid? The thyroid is responsible mainly for metabolism. So,
Right. But
yes.
what does that
So,
mean? High output failure. Why is the heart weaken?
okay. If somebody cannot give a normal cardiac output and they have to double the work, isn't it that you can consider it high output failure, that you cannot produce enough cardiac output, so there is a failure on the cardiac output. So when you don't have a good cardiac output, a normal adequate, what happens to the heart? It weakens because you need blood. The heart will say, hey, I'm having difficulty, I'm very weak, I need more blood, because there is low blood that is coming. It means the ventricle is failing. Why do you think the ventricle is failing? Because not all the blood from the atrium goes to the ventricle for the ventricle to eject the blood.
I get it. I get it.
Yeah, very nice, very nice. This one you know already, RAAS. Acute versus chronic heart failure. Yeah, this
No.
is just, you know that. Onset, acute onset, sudden onset. We already know
Oh,
this, right?
yep.
Yeah.
Is, um,
Yeah, you already know this, the endothelium and the vascular and tumor necrosis factor. Tumor necrosis, these are just tumor markers. You know tumor markers? So they will be tumor necrosis factor alpha. These are mediators, there are factors. So in case there is hypertrophy, fibrosis or fibrotic changes, apoptosis or cell death of the MI of the myocardial cells, then there is the presence of tumor necrosis factor alpha. So
and
there are
and what does hypertrophy mean again?
enlargement, honey, enlargement of the heart. Most, what part of the four chambers is enlarged? Usually it's always the left ventricle that is, while other part of the heart muscle can also enlarge, it's always the left ventricle.
Because there's
And
too much pressure, right?
yeah. So there is negative impact on inotropic function. Okay, I want you to look this up. What does inotropic means?
Okay, let me look it up.
Yes. Because there are this is a description of the heart. There is contractility, there is inotropism. I want you to know the meaning of
Okay,
inotropic. Inotropic.
it said medicines that change the force of your heart contraction. Positive inotrope strengthen the force of the heartbeat. Negative weakens the force of the
Very
heartbeat.
good. So what happens here? There is negative impact
Negative.
on the
So it weakens
inotropic.
the force of the heartbeat.
Yes. So I want you to understand, Monse. The heart is capable of contraction. It's called contractility. The heart, it's a heart function. The heart is capable of inotropism. Either it's positive or negative.
Okay, but
The
wait,
heart,
I thought that TNF was good because
uh-huh.
it's inflammatory mediator. I thought it was good. It's not, huh?
No, they're not good because they are okay, let's put it this way. They are regulatory mechanisms. When you say regulatory, Monse, what do you understand? When you regulate,
Regulate. They balance.
control,
They meet.
they
They
control.
control it.
They control. So, this one, I'm not saying they're bad, but then if it becomes positive, so it's a good control, right? It's positive. It becomes a negative impact. It's a bad control. So regulation is just like whether it has a good control or a bad control. So regulation is you are just trying to regulate for it. And what is the function of physiology, Monse? What is the main function of physiology? It
The
starts with the letter H.
the
Letter H.
the main of physiology.
Yeah, physiology, homeostasis.
Um,
Remember, that's the main goal of physiology to
right,
achieve
right.
what? To achieve what? Balance, right?
Balance.
Now,
Mm-hmm.
if there is a negative impact, do you think there's balance?
Mm-hmm.
No. So, the tumor necrosis factor, it has a negative impact. It's an inflammatory mediator. But then when it comes, oh yeah, you're correct. It has a negative impact. So, this is imbalance. So, the tumor necrosis factor alpha is an imbalance on the inotropic effects of the heart.
Right, because they only come because of all these things, and
Yes. Oh, you're very smart, Monse.
when
I'm
they
like,
come to mediate it, it has a
yes,
negative impact on the
yes.
heart.
When they mediate, very nice. I like it. You have to have very good grade here. Okay. Next. So these are regulator, the nitric oxide, the ADH. Remember, what does the ADH regulates?
Oh, the
There are two.
urine,
There are two.
urine, water and sodium.
Yeah, water and sodium. And where is the antidiuretic hormone? In what part of the
In
pituitary?
uh
P. P.
anterior.
No, posterior.
Oh,
What is in the posterior pituitary? The oxytocin and the vasopressin. And so the oxytocin is for, it's for lactation for mother. And then the vasopressin is for what? Mainly for water regulation. Water. That's why
okay,
vasopressin is here. So,
okay. Wait. How,
yes, now you
how about
understand.
this? How about nitric oxide?
So the nitric oxide is a vasodilator. It's just saying that as a regulator, as a control mechanism, the nitric oxide function is to vasodilate. That's it. It's just saying that it's a potent vasodilator. Like for example, okay, what is vasoconstriction, Monse? It's the airway is so little, right?
Yeah.
So whether there's blood flowing there or there is oxygen going there, if the blood flow is not going, so there's increased pressure, right? So in case of oxygen going there will be less oxygen. But nitric oxide, it's talking about oxygen, right? So let's talk about breathing. So in
Mm-hmm.
case of asthma, they have they have difficulty breathing. In case of dyspnea, right? What do? You give nitric oxide to vasodilate the airways so that they can really breathing. You understand?
I understand.
Yes. Once always remember, oh, if there is a pathology and there's vasoconstriction, what drug will you do? You give a vasodilator. Oh, if there's too much vasodilation, and then you give a vasoconstrictor. That's it. It's just the other way.
Get it?
Yes,
How about the how about this one? The ANS. Oh, I get it. Beta right here. Beta to increase.
what
This
is
is
ANS?
for
Autonomic nervous system. And what's
the beta
SNS? Sympathetic
one.
nervous system. PNS?
This
Parasympathetic nervous system. Right?
okay. This right here. This is for hypertension to regulate hypertension.
The metropolol, beta blocker. Right?
This one for hypotension.
Mm-hmm. Decrease heart rate and contractility. And cholinergic, mostly cholinergic receptors. There are two types of receptors, the muscarinic and the cholinergic receptors. The cholinergic receptors are mostly responsible for, they are, what's responsible for that? The acetylcholine. Remember the acetylcholine in the, what do you call that? I forgot the term, but it's neuromuscular junction. Remember, you can find the acetylcholine there in the neuromuscular junction. But then, if there is too much acetylcholine, then they will send the acetylcholinesterase to stop making or sending acetylcholine because you don't want also too much acetylcholine. So the acetylcholine goes back to the brain. All right. So it's a peripheral nervous system. All right. Next. Are there more, honey?
Uh, yeah, I understand this.
Yeah.
Um,
Whatever you don't understand because we've been 2 hours already. I understand, Monse, but you know what? You have to understand these things for you to understand the diseases because you have a patient. Oh, what's happening to the patient? You have to think right away. What's happening to the patient? You don't know. So you have to apply your pathophysiology. All right?
yeah, I already went over all this.
Good. And plus, Monse, you also have to read the book. Do you understand me? You have to read the book. Not really read, but then read some parts of it.
Okay.
I
Well,
suggest
um,
that, for example, chronic venous insufficiency, go to the page of the book with chronic, read a little, like a paragraph of two. I send
yeah.
you, did you know that I send you pictures of parts of my book? That's how I study. I don't read the whole book, but then I read the definition. Did you see? You
This
will see that.
this is right here. Right.
Yeah, yeah. There are some definition. So you can see that whether it's in your lecture or not, they're nice to know because Monse, you'll be taking this in the NCLEX.
Oh, I know.
Mm-hmm. So you have to know
Okay.
terminologies. So
Okay. So
when you talk about chronic is prolonged, right?
yeah.
Venous, this is related to the vein. And
Yeah.
insufficiency meaning there is decreased flow of blood. So
Yeah.
often results of damage to the bulbs in the deep leg veins. Insufficiency, but it's not really blood flow because blood flow is arteries. This is more of circulation. It
Yeah. I
means
I I get this one. I've seen this one before.
good, good,
So
good, good. Okay,
I'm good now
okay.
with every
With everything?
yes with everything.
Yes. And plus, Monse, if you have any question, you can text me on the group chat and I'll answer you. Okay? But I think you're good. I send you my cases. I send
Mhm.
you what else did I send you? I send you my quizzes. You
Mhm.
have to understand why that's the answer, and I also send you pictures and my PowerPoint slides. You're gonna be good, Monse. You have to get an A here.
Okay. And then how much do I owe you? We did 2 hours. I think that we already went past. I think we already did the hours for the past payment. So I'll send it to you on Venmo. Okay.
Yeah. Just send it to me. Don't worry,
2 hours,
Don't worry, Monse, about it. Yeah, don't
but
worry.
2 hours. Oh,
Yeah.
and then can you send me the recording, please?
Yes, I will.
Thank you.
Yeah. Okay.